All right, well, good morning, everybody. I want to welcome you all to our final grand rounds for the 2019 summer series or spring series. We're going into summer break after today, and we'll be back for the fall semester starting September 11th. So we'll miss you all, but we'll look forward to seeing you back, and we already have a lot of good talks lined up for the fall and winter. And I'm very pleased to introduce our speaker today. So Tim Gobble, he did his undergrad at Oregon State and then med school at Loma Linda, and he was a resident here with us. He was in my class. And one thing that I think all of us will always remember about Tim is that when we were doing our case discussions or really any kind of medical discussion, there was always a point at which you would sort of pause and look over and wait for Tim to say, now, you know, if you had an ultrasound for this, and then he would go on to teach us about ultrasound. He was way ahead of his time, and now, of course, ultrasound has changed the way many of us do medicine. And after he graduated from our program, he and his wife, Claire, who's a family medicine doctor, moved to Malawi. And the two of them are situated at a rural teaching hospital among the tea plantations in the southern highlands of Malawi, which is in southern Africa. He's the only internist at the hospital and one of just a handful in the entire country. And so he gets referrals from throughout the country for cardiac and infectious diseases and endocrine and neurology and pulmonary care. And the hospital he works at doesn't have a pharmacy or radiology, so Tim is also the de facto pharmacy head and runs the ultrasound department, radiology department. So we're excited to hear from him and what his experiences have been, and we can expect some good teaching on ultrasound, I trust. Welcome, Tim.
Well, thank you. Is this working? It's been an honor to come back to share with you guys some of our experience and some of the interesting cases and work that we're able to do in Africa. To start, just want to say I have no financial relationships to disclose. As Jesse mentioned, Claire and I have been working at Malamula Hospital in southern Africa. Here we are. This is part of a Seventh-day Adventist mission that was started over 100 years ago, and we've been there for 3 years. And as he said, we're surrounded by tea plantations. This is just outside the hospital. And in case... Can you guys hear me now? So in case you guys don't know where Malawi is, so it's in the southern part of Africa, just below Tanzania and inland from Mozambique. And our hospital is located in just the southern portion surrounded by Mozambique. And Malawi consistently ranks in the last place or next to last place in GDP per capita. And there's a severe shortage of physicians, as Jesse alluded to. In the US, we have more than 1 in 400 physicians, whereas in Malawi, it's 1 in 65,000. And most of these doctors do administration. Very few have specialty training or did a residency. So as a result, Malawi relies heavily on undertrained or underqualified health workers, such as medical assistants, clinical officers, they call them, with 2 to 3 years of training outside of high school. And these providers see most of the patients independently in Malawi. And in many cases, their education and the entrance requirements are not as much as the nurses that they work with. And as a result, the care is less individualized. It's more of a public health model. So everyone is treated with a handful of diagnoses and treatments. Our hospital has 200 beds. We see about 200 outpatients a day, 20 admissions. We have 2 general surgeons who run a surgical residency to train African surgeons. And so there's 5 surgical residents, 1 gynecologist. My wife, Claire, is family physician, and then we recently received a pediatrician, and then I'm the internist. And we have 9 mid-level providers who work like lifelong residents in most cases, and they do most of the C-sections, and they work very hard and do most of the care. So 4 years ago, they started the surgery residency, and it's brought the hospital up to a new level, and we get referrals from outside the country as well as all of Malawi. We have simple X-ray, and currently I'm in charge of a project to change it to a digital system and introduce a PACS system. We, of course, do ultrasound ourselves. We've also trained a technologist to do basic pelvic and abdominal ultrasound. And in the big city, which is about 2 hours away, there's a CT scan for the very wealthy patients and an MRI that doesn't work very well, but it can be used at the central hospital, although it's difficult for patients to get in there. We have a lab with basic chemistries, cytology, and rapid serology tests. We can send samples for pathology. Unfortunately, we don't have reliable cultures or sensitivities, and that's a blessing and a curse. But when it comes to other specialists, who can I refer people to? Occasionally, there's a nephrologist at the central hospital, and they do dialysis, but it's limited to those that are otherwise healthy and are likely to recover. And there is an oncology service there. If we get a tissue diagnosis, we can often send patients for chemotherapy, although they don't have radiation in the country. We really have no cardiologists. There's one that visits twice a year that I work with, and I see most of the cardiology patients get referred to me from the big city. And we have, let's see. So since I'm doing most of the ultrasounds, I have tried to teach the mid-level providers, Dr. Claire, my wife, become proficient, but still I do over 400 scans a year, and we regularly train the visiting medical students and residents that come from the U.S. And other parts of the world to work at Malamulo. In fact, and through the rest of the talk, I want to argue that ultrasound augments the physical exam and helps me to do things faster with less resources than might be done even here, where we have all the resources. So, and I put a handout. This is the first question on that handout, is what is point-of-care ultrasound? And just to review that, it's goal-directed, performed to assess relevant pathology, assessing specific questions. It's limited in scope. We're not trying to comprehensively look for any visible pathology. It's performed by the treating clinician at the bedside, and it's quick, it's repeatable. So it does not replace the sonographer or the echocardiographer, but in our setting, we don't have those. And today, we're going to focus on 3 interesting cases to show how we use it in this setting. So I'll start with first case. 23-year-old woman came into our hospital with 4 weeks of shortness of breath, chest pain, productive cough. She had some edema, orthopnea. She was HIV positive on the first-line therapy, and actually was treated for pulmonary tuberculosis a year prior. She had high blood pressure in a pregnancy about 6 months ago, miscarried, and wasn't on any other medicines. When we look at her, she was tachycardic, her respiratory rate was up, she was hypoxic on the maximum amount of oxygen we can give, which is 5 liters by nasal cannula. She was struggling to breathe. She had positive distended neck veins, rails throughout her chest, and dependent edema was found. We fortunately did get an X-ray, which I took a picture of, and we can see certainly many things going on in the chest. The heart might be big, although it's hard to tell. And so I'm going to pause here and talk about our differential diagnosis. Unfortunately, our X-ray didn't narrow it well enough. So we have to think of pericarditis in the setting of TB. We see quite a bit of that. Pericardial effusion could just give us distended neck veins, edema, although there may be something else going on. She could have decompensated cardiomyopathy. We see a lot of rheumatic heart disease and other valve disease. She could have right heart dysfunction due to changes from her pulmonary TB. We occasionally see pulmonary embolism, but that's would be another cause for right heart failure. And then, of course, there could be other things going on in the lung. She could have recurrent pulmonary TB, KS, pneumocystis, although she's been compliant with her medicines. So I'm going to pause here, and we're going to go through all these and see how would ultrasound be used to rule in any of these four categories. So we'll go through a couple of other cases. Here we see a case of significant pericardial effusion, and we can see this with a quick view of the heart. If the patient were hypotensive, it may be because the right heart can't fill because the fluid surrounding the heart is preventing that filling as it presses on the heart. And this syndrome, called cardiac tamponade, is unique in how we treat it, so it's important to identify quickly. We have to drain that fluid if the patient is in shock. And we do this about twice a year in Malawi. And most of that is due to extrapulmonary TB. So this is the fluid around the heart. Other times, there's not fluid, but the pericardium is just very thick. This is a pericarditis in a middle-aged male with HIV who was treated for TB, given steroids, and made a significant recovery. You guys can see that's the thickening of the pericardium. And then, of course, we can look at the heart itself and see how well is it squeezing. How well is the left heart working during systole? So we can get a gross estimate of the ejection fraction. And you can compare the two here, and you can see a difference. On the right, the walls of the left ventricle don't come together. The mitral valve doesn't open up very well. And all the chambers remain pretty full throughout the cycle. So this is our gross estimation of systolic function. And we're really just trying to tell, is it low, normal, and could it be contributing to our symptoms? And that will help us guide management. Do we need to afterload reduce with medicines? We don't have intubation or BiPAP here in Malawi, but that would potentially help a patient on the right if needed. We can quickly see, is there a valve disease? This was a young woman, 27, who presented with progressive respiratory failure. She had irregular heart rate, rolling diastolic murmur. Can you guys see what's going on? I think I gave it away. Here's the left atrium, and the mitral valve doesn't really open up. Okay, so she's severe mitral stenosis, and this is blood here that's not moving very well. There may be some clots in there. And she is someone who we need to manage her tachycardia. If we can slow her heart rate down, she'll have more time to fill her left ventricle. And she survived about a year on medical therapy, did worse anytime she stopped her beta blockers. We attempted to anticoagulate her as well with some donated enoxaparin. This was another gentleman, 77-year-old, presented with months of worsening respiratory distress, despite diuretics. I don't know if you guys can see what's going on here. So the left ventricle's big, and if you look at this is the outflow tract of the right ventricle, then the ascending aorta, and the left atrium. They should all be about the same width. In fact, the aorta is big, and you can see something flapping in there. You see that that's a dissection flap. And if we put color Doppler on the aortic valve, we can see significant insufficiency with the regurg jet taking up almost the full thickness of the valve. So this patient had an aortic dissection. If we scanned his neck, he also had a flap in the right carotid and down into the abdominal aorta. So this patient I've managed for 2.5 years. He's largely asymptomatic now on just medical therapy with full dose carvedilol, enalapril. We're treating his blood pressure with more amlodipine, and he's done very well. If we see the right ventricle is huge, then this could be a sign of at least isolated right ventricle failure. And you notice the left ventricle in this patient is very small. Whenever the right side is failing and it gets big, the left side can't fill. So these patients get severe symptoms that could look like this patient, but you can't tell until you look at the heart exactly what's going on. So we see this quite often as well. And let's compare that to biventricular heart failure, where the right heart's not working in this case as well, but it's likely due to the fact that the left heart is failing. So the management of these two patients is quite different. The patient on the right, we would like to give enalapril. We'd like to lower their afterload to treat the left heart failure. Whereas if we did that to this patient, the systemic pressure would drop and the coronary perfusion pressure would drop and the right heart would go into this downward spiral. It would be much worse. So both benefit from diuretics, maybe oxygen, but it affects our management. So this is helpful to identify. Then if we look above the diaphragm, we can see fluid in the thoracic space. This could be a complex pleural effusion here on the right, or more simple. This is easy to see with ultrasound. And when we look at the lungs, you may have been told, air reflects 100% of the ultrasound waves, and so you can't see anything below air in the tissue. But we can make significant, we can get good information from artifacts generated from the sound bouncing off the surface of the lung. In this case, when you have lung that's mostly air, it's normal, or it's hyperinflated, or it's a pneumothorax and there's literally just air in the chest, you get these horizontal artifacts that are a reverberation of the sound bouncing up and down, back and forth between the probe and that surface of air. And that creates these horizontal lines. These are called A-lines. And if we compare that to abnormal lung, let's say someone has interstitial fibrosis or cardiopulmonary edema, there's going to be more tissue or more fluid to air in the lungs, and the sound doesn't just bounce off the surface, it's going to bounce inside these interstitial spaces and then bounce out back to the probe, and it creates these vertical artifacts called B lines, and that's different from the A lines we just talked about, generated from normal lung or hyperinflated lung or just air in the chest. Now, if we see someone with significant pneumonia, the chest, the lungs are literally full of pus, we can scan through that. We can see a little bit of air in the airways. We can see the spine deep to the lung. Or let's say we have a pleural effusion and the lungs completely collapse. We can scan through that. So you can definitely make you can get good information when scanning the chest. So if we go back to our patient and her x-ray, we expect to find abnormal findings when we scan her lung, maybe when we scan her heart. So let's see. What do you guys think? This is when we scanned her heart. Is it normal? So when we were looking at the left ventricle function, we talked about the mitral valve. Does it open well? In this case, it doesn't. It doesn't come out and swing and touch the septum. Do these walls come together well? No. And if we look at the short axis, does the whole thing come together well? And when you look at these over and over, you get a really good sense immediately how well it's doing. And your clinical gestalt is about as accurate as doing fine measurements once you get experienced enough. We can also see a little bit of fluid in the pericardium down here. So she had pericardial effusion. The chambers were full. The ejection fraction is reduced. We don't see gross valve problems. When we look at her chest from below, we see this fluid around the heart. The chambers are full. And we note here how the right heart is filling. And it doesn't collapse. It looks like, although she does have fluid around the heart, it's not preventing flow into the right side. And we look at the IVC. This is just below the heart as the blood flows in to the right atrium. It's definitely full, and you can see the hepatic veins emptying into the IVC. So this is the patient's lung bases. So if we look here at the spleen, the left kidney, and the diaphragm here, just above it, there's fluid, although it's not very much. And then on the right side, we see the liver, the diaphragm right above it, and we can see a little bit of fluid and those B-line artifacts in the lung tissue, suggesting some edema. When we look at the lung surface itself, this was on the left side. If you notice, the x-ray was definitely more blown out on that side. She had B-lines, these artifacts coming all the way down, and less looking at the right anterior surface of the lung. So let's go back to our differential. Based on that scan, we found maybe she does have a pericardial effusion, although it's probably not the main cause of her problem. She definitely had a cardiomyopathy. We didn't notice any rheumatic heart disease. The right heart was not the problem. It was the left heart. We can't rule out tuberculosis with the ultrasound. So we definitely did some other tests for her. She had a TB PCR was done, was negative on her sputum. She had a urine test for a sugar specific for TB, and that was negative. She had a CBC, which showed she did not have anemia, which most patients with significant TB will at least have some mild anemia. And so we felt TB was unlikely her problem. Maybe this was a HIV-associated cardiomyopathy or peripartum cardiomyopathy. She was given diuretics and treated with afterload reducers, enalapril, spironolactone. She was put on carvedilol eventually and continued on her ARVs, given nutrition, and did quite well. So to give you guys an idea, remember where Malawi is located. We're right in this section here. We're in one of the hotspots for HIV in Africa. So this map, this was just recently published last month, shows in small areas, 5 by 5 kilometers, whether there's up to 300 plus patients with HIV, and in southern Malawi is a big spot for that. And unique compared to South Africa, Uganda or Nigeria, we have much fewer physicians, hospitals, much fewer resources to take care of these patients. So what ends up happening is there's no specialists that see HIV patients. There's no CD4 testing. There's no routine lab testing. No kidney function is checked while they're getting tenofovir. There's no genetic testing. There are second-line agents, but it's very hard to get viral loads done to get them onto those second-line agents. So it's a struggle, especially for those patients who have unique complications to therapy, like renal failure, or who have failed therapy, or have severe disease. So that's a struggle, but we do our best. I'm going to move over to the next patient. This was a 38-year-old female. She had 3 days of dizziness, palpitations, fatigue, otherwise no other symptoms. She had notable past medical history for anemia, although she was never transfused. She was given iron. She actually had, in her book, written that she had ascites and it was drained during pregnancy. She had normal deliveries, no surgeries. She was only on depot injections, did not report any bleeding, and had been tested negative for HIV in the past. Her mother had a history of anemia, and she was a subsistence farmer, like most patients, and frequently bathed and washed in the local river. So on exam, she was pale. She had mild scleral icterus. On exam, we noticed some mild murmur. Her abdomen was slightly distended. Notable, below the costal margin, we could feel her spleen, and otherwise her exam was normal. So in this patient, we don't have labs back right away, but we can assume that she has anemia and splenomegaly. So our differential in our setting would be recurrent malaria or other acquired hemolytic anemia. She could have a hereditary red cell defect and spherocytosis, thalassemia that wasn't previously transfusion dependent. She could have portal hypertension with cirrhosis, schistosomiasis, or a portal vein thrombosis, or like our last patient, heart failure. And then always on our differential in Malawi is extrapulmonary TB or other systemic infections or infiltrated process like lymphoma or other malignancy. So let's pause and see how we can use ultrasound to look at her spleen and then evaluate for causes of portal hypertension or for signs that would suggest an infiltrative disease, TB, etc. So if we look at the left upper quadrant and we measure the spleen at the longest or the widest diameter, the normal length is about 7 to 13 centimeters, and that's quick and easy to measure. We can also look for ascites, which would suggest portal hypertension. This is the right upper quadrant. You can see lots of fluid in this case, or in this patient, just a tiny bit. If we look on the left side, we can see a lot in this patient. We can look in the pelvis. We can see some fluid in the pelvis. And then this patient had lots of ascites fluid. But besides that, when we're evaluating for portal hypertension, we have to look at the portal vein itself, and we can measure that. Just as it crosses over the IVC in the longitudinal axis, if the portal vein measures more than 13 centimeters or 13 millimeters, then that's very specific for portal hypertension. And the bigger it is, the more specific. In this case, it's normal at less than 9 millimeters. And then we can always look at the liver tissue itself. In this case, you can notice the edge of the liver is nodular, and the whole liver itself is bright and it's suggests some parenchymal disease, maybe viscerosis in this case. And then, unique to our setting, we can look at for specific signs of periportal fibrosis. Now, schistosomiasis is a flatworm that can live in the mesenteric veins and deposit eggs into the portal system, and those eggs cause an inflammatory response, which leads to fibrosis around the portal veins. So it either can give you this pipe stem pattern, which we can see here, or just thickened, bright areas around the portal veins. And that's fairly specific for schisto. And then we may be able to see a portal vein thrombosis. This was a patient that had splenomegaly, recurrent upper GI bleeds, and intermittent ascites, and we scanned her and saw significant thromboses in her veins there. And then, of course, we can look at the heart and see, is there a significant heart failure? When we're looking for TB or lymphoma or other infiltrative process, we can look for lymph adenopathy around the aorta. So you can see this is a longitudinal view of the aorta here. This is the superior mesenteric artery, the celiac trunk. And if you look at enough of these, you can tell that this looks abnormal. There's all these round, dark areas here. These are enlarged lymph nodes. And this is something we look for when we're looking for extrapulmonary TB. And then we can look at the spleen itself. If you have TB or lymphoma, the spleen may give this leopard skin pattern. I don't know if you guys can see that. There's these small, dark areas throughout, and those are microabscesses, and that's a specific sign for some infiltrative process. And we'll often treat patients for TB just for having this sign if the rest of the picture suggests TB in HIV patients. So this was a 33-year-old male with HIV and extrapulmonary TB. So we took a look at our patient and we evaluated her spleen. Let's take a look and see what we found. It was big. So if you can't measure it all on one screen, it's usually big. Hers was over 17 centimeters. We didn't see any microabscesses. We looked at her portal vein, and her portal vein was big. So it was over 15 millimeters. And then we took a closer look at her liver and the portal vein, and we saw this thick and bright area around the portal vein. Now this is specific for schistosomiasis. And if we remember, she regularly washed in the river. So we didn't see any ascites, no pleural effusion, grossly normal cardiac function, and we did finally get some labs back. Sometimes that can take a few days. Her CBC was significant for some low platelets and anemia, but interestingly, she had severe microcytosis and a normal red blood cell count. And we did get a peripheral smear which showed some hypochromia. So all this suggests maybe she had a thalassemia or severe iron deficiency. She didn't have malaria. We did multiple tests for malaria. Liver function was okay, and kidney function was fine. We couldn't find any schistosomiasis eggs in her stool or her urine. We don't see schisto here, so I'm going to give just a few minutes to talk about it. Here we are in southern Malawi. We have both schistosoma, hematobium, and manzani. One affects the liver and lives in the mesenteric veins. The other affects more the bladder. So to give you a sense of what happens in schisto, you get exposed to fresh water that has the infectious forms. They penetrate the skin, and the adult develops migrates into your veins and then chronically produces eggs, which then can carry on the cycle, but it's the inflammatory response to these eggs that causes high rates of bladder cancer. It causes higher rates of HIV, chronic inflammation around the cervix, increases risk of cervical cancer. And then we see, as in this patient, portal hypertension. Some patients can get those eggs into the pulmonary circulation. They get pulmonary hypertension and right heart failure. That's something we see. And the process is carried on through snails that live in the fresh water. So this is a picture I took of Lake Malawi. And so if you go swimming, just know that the schistosomes are there. And this we stay at this house on the beach, and you just have to walk on the beach and you can see all the snail shells. And the snails do well when the local population overfishes all the shallow water fish. And there's been efforts to do mass drug administrations to treat this, but patients usually get reinfected very quickly, and so that's not very effective to manage. It really needs to be behavioral change, helping to improve water supply so people aren't using the river to wash clothes, and so that there's toilets. And we see this quite a bit. I think it's a problem that will probably persist in countries like Malawi. So our last patient we're going to talk about is a 23-year-old woman who had been sick for over a year, and her church rallied around her, got a bunch of money together, and brought her to see me. And she had came into the hospital on a stretcher, completely bedbound for 1 year after getting a fracture to her femur and her humerus, and she was seen in the central hospital. They did a bone biopsy and said it was negative for malignancy, and then she never followed up with them. So she came in with persistent bone and joint pain. She had nausea, anorexia, constipation, severe chest pain every time she took a breath. She was HIV negative, only on some pain medicines, and had been a house cleaner living in the city. No close contacts with TB or other disease. She had a 14-year-old daughter and a mother who was doing a very good job of taking care of her as she had been bedbound. When we looked at her, she had diffuse muscle wasting and severe swollen right shoulder and right thigh, which were deformed, and I can show you a picture. But most notably, she couldn't move any of her joints except for her head, her jaw, and her fingers. Everything else was fused. She was having trouble breathing. She had a sunken chest, a systolic murmur, and you could feel stool in her belly. She was otherwise cool and clammy. And here's a picture of her leg. You can see severe deformity, and I don't have the x-rays from her initial presentation, but the whole shoulder had calcified, and this whole area had calcified, and around the joints there was a lot of extra bony tissue being formed. So we did have a few labs that came back quicker for this patient. She had some mild anemia, elevated platelets. Kidney function wasn't terrible, but significantly elevated alk phos. Otherwise normal liver tests. HIV test was negative, and we did scan her initially and found that no sign of heart failure. She didn't look like she would have any problem receiving some fluids. She had no collections in the chest. Her IVC was small and collapsing, and so we did give her some fluids. And again, looking at the x-rays, she had severe displaced humerus and femur fractures and calcium deposits in the periarticular tissues. And it was about 2 or 3 days later that we got the calcium result. Her calcium was severely elevated, normal TSH. So we were able to give her some fluids, treat her constipation, and miraculously she had no bed sores that had developed. Her mother had done a very good job taking care of her. So let's go over a differential for this. We felt like the most likely diagnosis was osteitis fibrosis cystica due to untreated severe hyperparathyroidism. Unfortunately, at least at the time, there was no way to test parathyroid hormone levels. She could have had a malignancy, multiple myeloma, although she had had these symptoms for a year and no severe progression, nothing had declared itself in a year's time. She could have TB, but the same thing, nothing had declared itself. She didn't have any other specific signs for TB. And since then, I figured out a way to send blood to South Africa to test parathyroid hormone level, but we didn't have it at the time. And we couldn't measure vitamin D levels either. But she denied taking vitamin D or any calcium supplements. So I know if you read up to date, you're not supposed to use imaging to diagnose hyperparathyroidism. But we said, well, why don't we look at her chest or look at her neck to see if she has any obvious adenoma that could be removed. And so the surgeons, with myself, we scanned her neck, and she had this cystic structure right underneath the clavicle on the right side, below the right lobe of the thyroid. And you guys can see it here. It's moving up as she swallows. I'm asking her to swallow with this clip. And you can see it measures around 2 centimeters. This is transverse view. This is the trachea, the thyroid up here, and as I scan down, you can see it come into view here briefly. So the surgeons said, well, that's close to the surface. We could take that out. And if the calcium drops dramatically after you take that out, it confirms the diagnosis. So she underwent an uncomplicated 20-minute surgery and repeat calcium. It had come down with fluids, but it was normal the next day. And in fact, she went on to develop symptoms of hypocalcemia and severe hungry bone syndrome. And fortunately, we had vitamin D and Tums, and I think I put her on about 14 tablets of calcium carbonate per day and titrated that down over a year and a half. And she's made a remarkable recovery. She only struggles now with having one leg that's much shorter than the other. And this is, so all her other joints have function now. We've been able to get her therapy. So this is an x-ray of her healed fractures. So I'm not advocating that we do parathyroid ultrasounds to diagnose this here, but it shows how, in our unique limitations in Malawi, we can use ultrasound to really make a difference. And when it comes to internal medicine, what things can we do? I think we were all taught how to use ultrasound to guide procedures. And as our first case illustrates, we should be using it in patients that present with respiratory failure as well as shock. We can see patients with abdominal distension. Do they have ascites? What's going on? We can see bowel obstruction, and we can obviously evaluate organomegaly. We can look for fluid intolerance. Is this patient going to be benefiting or harmed is a better question. Are they going to be harmed by the fluid we might give them? We see lots of kidney injury. Half of our HIV patients die of kidney failure. This is it's good for that even in this setting. And then obviously soft tissue swelling. Although we don't see a lot of DVTs, we do diagnose some of those. So I think that's all the time we have. I'll leave this to questions. I put a handout up so that we could answer basic questions about point of care ultrasound, but maybe people have other questions.
So, Tim, that was great. Two practical questions. What's the current cost US for a point of care ultrasound for the device? What's the equivalent cost? And secondly, is there a language barrier in Malawi? You did so well. Do you need an interpreter, or are they conversant in English?
So yes, most patients speak Chichewa, and if they've gone to school past high school, they'll speak English, or if they were lucky and the parents spoke English to them. So the British colonized Malawi, and it was a colony up until the 60s, so the educated speak English. So it makes that easy. And we get translators. I've learned a little bit of Chichewa. Claire has learned more than I have to speak to patients, but we usually use a translator. As far as the ultrasound machine goes, the one we use it's about 25,000, and that's used from the manufacturer, and that's a nice machine from the US. You can buy for a few thousand a much lower quality machine from China. And I know there's handheld devices that are down to 2,000, but those have the functionality is not the same. So I'm not advocating a whole hospital rely on those. We have two $25,000 machines we raised money for and got before I came. Yes, sir.
That's fantastic. A couple questions. I just heard a lecture about the PEPFAR program to fund more into the treatment and diagnosis of that in developing countries, especially Africa and India. Where is that? Is Malawi, is that on the list? And then the other thing is, you have very unique population, and you talk about TB in all the differential diagnoses, and what about syphilis? Can you talk a little bit more about what you're seeing with complications and other forms of TB shows itself in that particular country?
Yeah, so PEPFAR funds a lot of our HIV meds. The meds are all free. Patients can get them. Again, it's free, but you're in this public health model, so if you have an individual unique problem, it's hard to get treatment tailored to you, but all the meds are free. They fund HIV testing, and
Do you have other organizations working on the ground to get those medicines and get people treated? Sounds like that's a problem.
yeah, in fact, actually, the HIV rates in Malawi are going down as opposed to Mozambique. They've gone up. I think they do a good job getting them out to everyone. Again, it's having the expertise to tailor it to a specific patient. In fact, sometimes we have more meds than we need. And it's the patients in the very rural villages that may not be diagnosed yet. That's the problem. As far as TB goes, we see a lot of patients that have low CD4 counts, and so they don't present the same way. They'll have a normal X-ray, negative sputum testing, but they'll have severe anemia, severe weight loss, and in that case, we just rolled out this test that looks for a sugar in their urine, and that's helped us, but in many cases, we just treat empirically. That's probably the most common presentation, but otherwise it's pleural effusions, pericarditis, or pulmonary TB. There's some TB meningitis as well. Yeah.
I was just curious about the outcome for your second patient.
Yes. So we put her on iron, folate, and gave her a transfusion. And this was the patient with schistosomiasis, maybe thalassemia. We have no way to confirm that. So we put her on, and I suspect if it was thalassemia, it was non-transfusion dependent. And maybe she has now developed hypersplenism from her portal hypertension, and that with the thalassemia put her over the edge. Her hemoglobin is lower. So she was transfused, treated for schisto with praziquantel. We treated her for other hookworm infections with albendazole, which can cause GI bleeding, and then ask her to follow up and periodically check, and then have her at least attempt to not wash in the river if she can, because they can get reinfected. Although her problem may not go away. That's chronic fibrosis there. Yeah. Yes.
I am not from Malawi, I'm from Uganda, but I want to thank you after seeing your presentation. I want to thank you and your team for serving the people of Malawi. There are few people who do what you do in Africa. And particularly when I see your diagnosis, to me, comprehensive, and that's very
Thank you.
One more question here. The third patient, when it's a thyroid, hypoparathyroidism, she's 28, something like that? 23?
Yeah, 28.
And, you showed us a 1 year after her x-rays of her lung bones and that type of thing. Sarah, I don't know what the resources are, but yeah, if you have access to endocrinology, orthopedic surgery, is there some, or do you expect that over time, you got to tweak the biology a little bit to see if there could be remodeling. That's what I'm thinking about, those legs, so that she could be more functional and run. And maybe the resources aren't there.
Yeah. So regarding the third patient, we showed the x-rays to an orthopedist visiting from the U.S., and it doesn't sound like there's any surgery to lengthen her leg, which is her main issue now. It would be very difficult, probably make it worse. So the best thing would be to give her a shoe that's about 3 inches thicker so that she could walk, and then just train her. She's otherwise doing well. She is not walking very well because of the leg issue. But otherwise I don't see her very often now because we've got her basically off of the calcium. It'd take about a year and a half.
Well, thank you, Tim, very much.
Oh, thanks.
How do you manage personally? What I can see is there's a problem. You have to keep up with your medicine.